Hello. Today we're going to talk about virtual reality, a tool for the occupational therapist. Virtual reality is an exciting avenue for the occupational therapist in that it offers a means to engage our patients in activity that encourages repetition, provides feedback, and enhances motivation. So what is virtual reality? From Merriam and Webster, virtual reality is, quote, an artificial environment which is experienced through sensory stimuli, as sights and sounds, provided by a computer in which one's actions partially determine what happens in the environment. Also, the technology used to create or access a virtual reality. There are three primary means of virtual reality. First are headsets. Headsets provide a three-dimensional environment and full immersion into the activity. Headsets are an excellent way for a patient to get a real sense of a particular simulation. Flight simulators are an example of a total immersion virtual reality systems. Headsets can be cost prohibitive and may cause disorientation or cybersickness. Screen-based systems are less expensive, and there are many off-the-shelf versions such as the Wii or Kinect, or more sophisticated versions that allow for parameter manipulation, such as the Omni VR. Screen-based systems are less expensive and can be used either by laptop or flat-screen monitors. Haptic systems. Haptic devices or gloves are used commonly for providing feedback for extremity function. Sensors caption movements which then can direct object movement or feedback on a screen. While excellent for working with patients who have motor impairments, haptic systems can be cost prohibitive, and there may be difficulty with donning and doffing as well as infection control. There are a number of benefits to virtual reality. As such, they provide for an ability for the participant to become immersed in the activity. We all know somebody who is notorious for being late for dinner because they can't seem to pull themselves away from their video game. Virtual reality activities allow for immersion to occur, at which point the patient may not feel like they're in therapy at all, and are focused externally on the activity or task. The therapist is an integral component of the activity, not an observer. This is a very, very important point. The virtual reality activity allows for the therapist to insert their skill into the activity by providing a number of cues, be it tactile, visual, verbal, or posture. A key point is that the virtual reality activity or game does not stand alone. If the therapist does not participate in the process, then the activity may not require the skills of a therapist, and there also may be a risk for documentation and reimbursement challenge. The degree of difficulty and level of gradation is determined by the therapist. As such, when virtual reality is used correctly, the therapist should use the opportunity to increase the degree of challenge and difficulty based on the therapist or based on the patient's abilities. If the activity is too easy, the patient may become bored and may not want to continue. If the degree of difficulty is too difficult, the patient may become frustrated and as well may not want to continue with the activity. Virtual reality activities encourages high repetition of a selected task. A properly selected activity should be matched to an impairment area and encourage the patient to focus on the task rather than rote movements that may not have a context, such as placing a peg in a hole, stacking a cone, bouncing a ball, or pushing a balloon through the air. Virtual reality incorporates cognitive, visual, and motor challenge. Real-life activity, as well, has multiple sensory and motor demands. The virtual reality systems may provide feedback and challenge in these three areas that will enhance a patient's ability to engage in ADL in the community or in home setting. Let's take a look at some of the research. There's been a large upswing in research on virtual reality in the past 10 years, with more randomized control trials and meta-analysis occurring. There is still a need for continued research to provide additional data, detail, and information on mechanism of action, as there are many theories to its benefit, yet no conclusive findings. The majority of research concludes that while more research is needed, there appears to be a viable therapeutic benefit when incorporating virtual reality into the existing treatment plan. It's important to note that virtual reality does not take the place of therapeutic intervention. It is an adjunct. From a cognitive standpoint, this randomized controlled trial conducted by Kim and Lee in 2005 noted that patients were motivated by experiencing a diverse and stimulating environment through the virtual reality program, resulting in the improvement of attention and memory. In this particular study, the VR group showed a higher increase in the STAR cancellation test and CBS scores after treatment, meeting the threshold of 0.05 on the p-value. From a visual spatial standpoint, this randomized controlled trial, conducted by Kim and Chun in 2011, noted an improvement of visual attention and short-term visual spatial memory after treatment with the virtual reality program. Noted. The visual continuous performance test met the p-value threshold of 0.01, and the backward visual span test met the p-value of 0.05. From a motor standpoint, this meta-analysis, conducted by Saposnik in 2011, noted 11 of 12 studies showed a significant benefit towards virtual reality for the selected outcomes, specifically the Fugl-Meyer, the Wolf Motor Function Test, and the FIM. Also, virtual reality systems apply relevant concepts for driving neuroplasticity, such as repetition, intensity, and task-oriented training of the paretic extremity, and lead to benefits in motor function improvement after stroke. The odds ratio in the study favored statistical significance, meeting the p-value threshold of 0.018 for improvement of motor impairment. In summary, key points. Virtual reality is an approach to treatment, not the treatment itself. There are some that feel that virtual reality activities diminish the role of the occupational therapist. This may occur if the therapist views the activity as the therapy and does not incorporate gradation, challenge, or prompts and cues. The therapist must be present and actively providing proper cues, guidance, and direction. This is very important. This is what makes activity skilled. Following participation in a virtual reality activities, patients should then work on an ADL task that requires the cognitive or motor skills that was emphasized during the virtual reality activity. The activity must be customized to provide graded challenge as the participant progresses. This is the risk of using off-the-shelf gaming activities, in that the therapist may stand and watch the participant engage. As well, off-the-shelf gaming devices, while there are many benefits, do not have the ability to have their parameters manipulated by the therapist. The therapist then needs to be creative in how they provide cues to challenge and grade the activity. The therapist must track skills and provide translation of skills into practical, measurable function. This is of utmost importance in that data collection and outcome measurement must occur for this to be a properly used skilled activity. Information such as accuracy, response time, left versus right response and accuracy, level of distraction, duration of activity, number of cues required, or the amount of steps required in an activity are all critical points with justifying, again, this activity to be a skilled occupational therapy activity. I hope this provided a basic introduction into virtual reality and its role in occupational therapy. Thank you.